All right, so let's kick things off this evening. This is our March edition of LVS Film Reading. Hopefully, you've all had a chance to take a look at the 4 cases that were sent to you late last week. And so you're feeling reasonably confident about potentially having to present one of these cases this evening. Just before we get on to discussing the cases, just a very quick introduction. So my name is Ian Jones, and I'm the radiologist at London Veterinary Specialists, which is a multidisciplinary referral hospital in the very heart of London. And if you guys need any assistance at all with anything imaging related, even if it's just to have a chat about what the most appropriate imaging modality might be for a particular case, then don't be shy and either give us a call or drop me an email at this email address. So this evening's session is an interactive session. So the idea is that we try and create an informal environment for us to discuss some interesting radiographs. So this is very much a session where you guys are going to contribute. This isn't a lecture, so I'm not going to talk at you for an hour. I'm hopefully going to get to find out what you guys thought of some of these cases that I've selected from our interesting case log. Like I say, this isn't an exam. None of these patients are in any danger. So these are all historical cases that I've seen over the last 3 to 5 years. So there's nothing at all to worry about or to get stressed about. So please, I would encourage everybody to contribute, because the more you contribute, the more you're likely to get out of it. Now, before I ask you guys to add your 2 penneth, we're just going to run through an example case. So when these cases get sent out to you, what I'd encourage you to do would be to take an hour or so to look at each case, spend roughly 15 minutes per case, evaluating each of the radiographs and producing just a very brief radiology report. And that report should be split into 3 sections, essentially. A section that contains your radiographic description, and that's a chance for you to use as many radiological terms as possible to try and describe the changes and the lesions you think may or may not be present. A section for your conclusions, where you can list your differentials, and in some cases it's going to be a slam dunk, and you're going to be very confident that this patient definitely has GDV, for example. But there's going to be other cases where it's a little bit more woolly, and you have any number of differentials. Even in those cases, I would encourage you to rank them and be able to justify the ranking. So these lesions could be compatible with, say, heart failure or non-cardiogenic edema or pulmonary eosinophilic granulomatosis, and then be able to justify why you've ranked the lesions in the order that they're presented. And then finally, some recommendations. So if you're not able to reach a definitive diagnosis and you think that that patient might benefit from some additional imaging, then the recommendations section is the time to suggest that. So for example, if you think that the radiographs are compatible with, say, a foreign body and a mechanical ileus, but you would suggest that an ultrasound might be able to nail this on, then it's entirely appropriate for you to suggest the patient have an abdominal ultrasound. So the example that I've chosen is a 5-year-old crossbreed that has presented to you as suffering regurgitation, and it's also pyrexic. So this case, we have a right lateral radiograph and we have a dorsiventral radiograph. So for this case, I will summarize the radiographic changes. I'll give you my conclusions and any recommendations I might have. In this right lateral radiograph, we can see that the esophagus is dilated with gas, as evidenced by a tracheal stripe sign. We can see both the dorsal and the ventral borders of the esophagus, which are just here and just here. We can also see that in the ventral thorax, superimposed over the cardiac silhouette, in this region, we have a radiolucent arborizing structure, which probably represents a bronchus. And this appearance is very much compatible with an aeobronchogram. The pulmonary parenchyma surrounding the structure has an increased radiopacity relative to the parenchyma adjacent to it. So the presence of an aeobronchogram and that increased opacity is compatible with a focal area of lung consolidation. So in this radiograph, to summarize, the changes are a markedly dilated esophagus and a focal area of consolidated lung. If we look at the DV radiograph, we can see that that focal area of consolidated lung is on the left, and if we wanted to localize it to a specific lung lobe, it's most likely the left cranial lung lobe. There aren't really any other additional changes in this DV radiograph. So to summarize, we have a markedly dilated esophagus compatible with a megaesophagus. We have focal consolidation of the left cranial lung lobe, which would be compatible with an aspiration pneumonia. So this dog has a megaesophagus and it has an aspiration pneumonia associated with that. So I wouldn't necessarily recommend any additional imaging for this patient. I think these radiographs are diagnostic. And at that point, I would move on to the next case. So that's the sort of description and the sort of approach that we're looking for in these sessions. So without further ado, we have our first case, which is an 11-year-old female entire crossbreed dog that's presented to you as being dyspneic. Now, this patient has 3 radiographs. So you have a right lateral, you have a dorsoventral, and you have a left lateral radiograph. So at this point, I am going to give up the floor to one of you guys who hopefully would like to share their assessment of this patient's radiographs. So who out there would like to take this first case? Is there anybody feeling brave enough?
I'm happy to give it a go, Ian, if no one wants to.
Yeah, absolutely.
Okay, so I think we have a left and right lateral thoracic radiographs and one DV. I think on the first one, the right lateral, you can see that there's kind of marked narrowing of the tracheal lumen affecting kind of the cranial half of the intrathoracic trachea. If you can't see any of the cervical trachea. I think there's kind of a diffuse, perhaps alveolar pattern on all 3 radiographs. And then if you go to the left lateral one, there's kind of a marginated soft tissue opacity in the ventral trachea, ventral thorax. So I think the most likely differential is tracheal collapse. I guess other things could be like tracheitis or hyperplasia, but I think they're more likely to affect the whole trachea rather than just part of it. So I think the recommendation would probably be fluoroscopy and maybe surgery. Okay. And then I guess I was wondering if that soft tissue opacity was maybe like secondary collapse from secondary lung collapse.
Okay. And is this the opacity that you're referring to here?
Yeah, I wasn't sure what that was.
Okay. Yeah, no. All right. Okay. Yeah, so I've been a little bit sneaky here, and I haven't told you what sort of dog this is. If my memory serves me correctly, this is a medium-sized crossbreed dog. So it's about 20 kilos, this dog. Now, that doesn't necessarily mean we can completely rule out tracheal collapse, but it's much less likely than if this dog was, say, a Yorkshire Terrier. The other thing that you mentioned was a diffuse alveolar pattern. So can you expand on that a little bit? What made you think that there was a diffuse alveolar pattern here?
So I think I think what I was seeing was kind of diffuse rather than focal. I do struggle with the lung patterns. So I think I was seeing some kind of donuts. So on the DV, I think.
No, I think that's true. So I think in all of these views, we can see a few little donuts. So it's DV view, there's a couple of little donuts both on the left and on the right. And in the lateral views, again, there's some donuts, particularly in the dorsal caudal line. We also have some tram lines as well. So in this lateral view, we can see some tram lines here and some tram lines here. Trickier to see, but again, in this left lateral, there's definitely some linear radiopaque mineralized structures that are adjacent to each other that are compatible with tram lines. But for donuts and tram lines, what sort of lung pattern should you be thinking about rather than an alveolar pattern? So donuts and tram lines are indicative of a lung pattern, but not alveolar.
Bronchial.
Yeah, absolutely. So I absolutely agree that there's some evidence of bronchial disease here. And I think the evidence is the fact that we can see these donuts and tram lines. And that's indicative of some bronchial thickening. But this is a slightly older dog. So this dog is, I think, 11 years old. And most older dogs are going to have some degree of bronchial thickening and or mineralization of their bronchi and bronchioles. So we can't completely rule out something like a chronic bronchitis in this dog, but in all likelihood, the donuts and tram lines that we're seeing here are probably just an incidental age variant. But a bronchial pattern and the presence of donuts and tram lines is not the same as an alveolar pattern. So an alveolar pattern is something that you can really only be super confident about if you can see a bronchograms. So an alveolar pattern is indicative of a consolidation of the lung. And the reason you can see the bronchograms is because the rest of the lung, so the alveoli and the interstitium, are completely filled with infiltrate, which means that the gas within the adjacent bronchus is more visible. And that bronchus that's surrounded by infiltrate within the alveoli and within the interstitium is the bronchogram. So you can be confident about calling a pattern alveolar if you can see bronchograms. If you can't see bronchograms, then it could be just an interstitial pattern. So if the pulmonary parenchyma has an increased opacity, but you can still see the constituent lung architecture within it, so if you can still see the pulmonary vessels, for example, and you're not seeing bronchograms, then you can call it interstitial. If you're seeing bronchograms and everything else is just whited out by the infiltrate, then it's alveolar and it's completely consolidated. But this pattern is a bronchial pattern. I agree that this area of increased opacity in the ventral thorax here is abnormal. And there's also an area here in the right lateral view that is increased in opacity and is also abnormal. And I completely agree with your assessment of the trachea. So the lumen of the caudal cervical and cranial thoracic trachea is markedly narrowed in this right lateral view. It's pretty tricky to see it in this DV view. These probably represent the left and right main stem bronchi just here, and the trachea is here. I can't really appreciate the narrowing, but in the left lateral view, again, we've got marked narrowing of that caudal cervical trachea and that cranial thoracic trachea. Now, it could potentially be a tracheal collapse. It doesn't look typically like a tracheal collapse. So patients with tracheal collapse, the trachea tends to squish up during very specific phases of respiration. So the cervical trachea tends to collapse during inspiration and the thoracic trachea during expiration. And You can see that during fluoroscopy, and if you're very quick on the draw with your exposure button, you can pick that up just on plain radiographs if you're very careful about when you're making the exposure. Here we've got narrowing of the cervical trachea and the thoracic trachea simultaneously, which is a little bit strange for a tracheal collapse, particularly in a larger dog. This dog, as I say, was sort of a collie cross. It was around 20 kilos. So we can't completely rule it out, but it would be a little bit strange, and this doesn't look like a typical tracheal collapse. And also we've got these other areas of increased opacity in the ventral thorax to think about and try and decide what they might be. So does anyone have any ideas what we might be looking at in this ventral thorax? You can see it in the lateral views, not so much in the DV. Any other suggestions as to what might be going on there?
I thought maybe mediastinal mass, because you can see it on the lateral view, but then when you go to the cranial, that one,
yep.
You cannot really see it, but there is, I would say, a little bit of increase of soft tissue opacity in the mediastinal area.
This area, yeah. I mean, I wouldn't disagree that mediastinum is maybe ever so slightly wider than it should be. In the lateral views, a mediastinal mass typically would have more of a cranial and ventral location, so it would be more in the cranioventral thorax, just here, rather than superimposed over the cardiac silhouette. And usually if you have a mediastinal mass, you have a space-occupying lesion, so the structures around it are going to be displaced. And we're not really seeing a displacement. We're seeing a narrowing of the tracheal lumen, but not really a displacement of the trachea. So when we're seeing an increase in opacity in the ventral thorax, and we're seeing this sort of conformation where there's a diagonal linear border between the area of opacity and then gas-filled lung, what should we be considering here? And don't forget, this patient is dyspneic.
I'm not sure if you can hear me.
Yeah, I can hear you.
Well, I think it's a pleural effusion.
Absolutely.
On both sides, more
yep.
obvious on the right lateral one.
Yeah.
Yeah, and then. But that's I'm not sure about the origin, of course, but that I think that's what those lines are telling us.
Yeah, I absolutely agree. So we've got some effacement of the ventral borders of the cardiac silhouette here, and then we've got this diagonal border, which most likely represents a pleural fissure line, which is exactly what it is. So this is a pleural fissure line here. This is a small volume pleural effusion, and we've also got the suggestion of maybe another pleural fissure line cranially and ventrally. You can't really see it in the DV, so in a DV or a VD, what you'd be looking for is some pleural fissure lines and also the suggestion of retraction of the pulmonary parenchyma from the thoracic wall. And we can't really see that in this DV view. So for very small volume pleural effusions, a VD view is more likely to show it up. So probably the reason why we can't see it is because it's a DV and a lot of the fluid is just pooling in the ventral thorax and is not really showing up particularly well. But I absolutely agree that in both the lateral views, we've got an increase in opacity, we've got effacement of the cardiac silhouette, and then we've got some pleural fissure lines. So this patient has a small volume pleural effusion, no question. So if this patient just had a tracheal collapse, we wouldn't necessarily expect there to be a pleural effusion. So the signalment of this patient doesn't really fit. And also the radiographic changes don't entirely fit with a straightforward tracheal collapse, because why would a dog that has tracheal collapse have a small volume pleural effusion? So my question to you guys is there a way that we can link the two? Is there something that you may or may not be aware of that can present like this, where you have marked narrowing of the tracheal lumen, and that could potentially be associated with other radiographic changes, in this case, a pleural effusion? Is there anything that anybody would like to suggest? And it's one of those things that if you've never seen this, before, you're going to struggle to guess what it is. But once you've seen it once, then you're not going to forget it, which is why this case is in here. Nobody can think of anything that can link the appearance of this tracheal lumen and the presence of pleural effusion. Okay, so I'm just going to elaborate ever so slightly on the history, which was pretty meager. So this, as I say, is a collie cross. It lives on a farm, and the farm has a pretty big rat problem. Does that give you guys any more of a clue as to
rodenticide poisoning?
Yeah, absolutely. So these changes, particularly the changes to the tracheal lumen, are pretty pathognomic for rodenticide toxicity. So this patient had ingested rodenticide and was actively bleeding, and that explains the pleural effusion. So the small volume pleural effusion is blood in the pleural space because this dog was coagulopathic. Now, you might ask, well, why would that make the tracheal lumen look narrow? And the reason for that is that dogs with rodenticide toxicity quite often bleed into their tracheal mucosa, and their tracheal mucosa swells up. And because the tracheal mucosa swells up, it makes the lumen look very narrow. And that's what's happened here. So this dog has come from a farm. It's ingested rat poison, and it's become coagulopathic. It's bled into its pleural space, which is why there's a small volume pleural effusion, and it's bled into its tracheal mucosa, which is causing its mucosa to bulge into the lumen, and that bulging mucosa is making that tracheal lumen look really narrow. So this patient has rodenticide toxicity. Now, like I say, if you've never seen one, then it's pretty tricky to guess. But now that you've seen rodenticide toxicity and what can happen to the trachea and the tracheal lumen, then hopefully you'll not forget it. So yeah, this patient is a rodenticide toxicity. So yeah, nice job. Does anybody have any other questions about this case?
Ian, I was just wondering, is it the trachea or the small volume effusion that makes them dyspneic?
In this case, probably a combination of the two. So the pleural effusion is very small volume. So it's difficult to say objectively how much effusion there needs to be on a radiograph to cause clinical signs, but subjectively it looks like quite a small volume effusion, whereas the trachea looks markedly narrowed. So if I had to guess what was causing this dog's dyspnea, I would say it's the narrowing of the tracheal lumen.
Okay, thanks. And sorry, would you mind just pointing to the fissure lines again, please, if that's all right?
Pointing to the fissure lines?
Yeah, if that's all right, cheers. And where was the other one?
So this could be a little fissure line as well, between the right and left cranial lung lobe. This is the main one. So this is the one that we should be picking up on, particularly because there's definitely some increased opacity here.
Okay, thanks very much.
Can't really see it in the DV, and then it's tougher to see in the left lateral, but it's definitely there. All right, everybody happy with that? So if you guys come across a dog that has a trachea that looks like this, then rodenticide toxicity should definitely be on your differential list. All right. Okay. Good job. So case number 2 is an 8-year-old female neutered beagle that's presented as vomiting. So you guys have 2 radiographs. You have a lateral radiograph, probably a left lateral, and you have a DV radiograph, which is not the most useful in terms of its positioning and its exposure, but you have it all the same. So who would like to have a crack at this little beagle? Any takers? So for the guys that have already contributed, I think it's really only fair to do one case per session. So I don't necessarily want the same people to be contributing to every case. But yeah, if somebody wants to have a crack, that would be great. Because otherwise, it'll just be me telling you about cases that I already know the answers to.
Well, I can do it if you want.
Yeah.
Hello to everyone. So just to let you know, the quality is not great.
No, it's poor.
And I mean, yeah, it's going to be a bit difficult. So we have two projections. One is probably left lateral, probably right lateral, and the other one is a DV, we said. So of abdomen of a skeletal immature dog. So we can see there are some like newborn projection between T13 and L1 that they are, essentially it's not bridging, is like unstructured, but like it's not clinical significant in this case. Well, regarding the abdomen, we can see there is a sort of loss of serosa details on the dorsal aspect of the abdomen.
Yeah, absolutely.
I can really well recognize the kidneys essentially.
Yeah.
Also, it seems to be like two population of small intestinal loops.
Yeah.
Although it's not really clear, and some of them they are gas filled, and the colon is maybe displaced a bit dorsally, and in the caudal part of the colon, just on the descending, like on the part close to the rectum, essentially there is some mineralization also within the colon, and I can recognize the bladder. Probably there is superimposition, effacement of the thigh, and there is poor details. And what else? We can see the tail of the spleen, and the liver seems to be within the costal arch.
Yeah.
And if this projection is right, I mean, I cannot see any like gas within the stomach fundus, and it looks quite, I mean, a soft tissue opacity within the gastric axis.
Yep.
So, the dog is presented for vomiting, we say.
Yeah.
It's a beagle. Cool. Well, it's a bit tricky. I mean, usually with this, poor serosa details and overcrowding of the dorsal part of the abdomen, dorsocranial, I will put pancreatitis as differential diagnosis. I cannot rule out a foreign body also.
Yep.
But, I mean, to be honest with you, I mean, if we check the small intestine is not so dilated, but I mean sometimes it doesn't mean anything.
Yep.
Can I ask for an ultrasound, abdominal ultrasound?
Yeah, you absolutely can ask for an ultrasound. So I absolutely agree with your interpretation there. I think you've picked up on pretty much all of the changes that I was hoping that you'd mention, and particularly this loss of serosal detail in the mid-abdomen here. And I'm glad that you mentioned the stomach as well. So the stomach doesn't look particularly dilated, but it is quite opaque. We would normally expect to see more of a gas lucency, particularly within the gastric fundus, and it's almost entirely uniformly opaque in the soft tissue opacity, maybe a little bit of gas in the most non-dependent part. And I don't think we need to look at the DV because it's essentially useless. So the DV doesn't help us at all. Now these were the radiographs that that I was given when I was asked to help out with this case. This is a duplication of how this case presented in real life. So these are the radiographs I was given. I agree that they're not the best. I think the lateral is helpful, and I think there are certainly reasons to be concerned about this abdomen because of the changes that you've just summarized. But this DV is essentially useless for lots of reasons. So for abdominal radiographs, I'd always recommend a VD rather than a DV. The exposure is poor, so this is effectively underexposed, and the positioning is very poor as well. So we're not really able to evaluate any of the abdominal organs. We can just about see the spleen, maybe a little bit of the stomach, a little bit of gas in the bowel, but that's not a very useful radiograph. Okay, you request an abdominal ultrasound, and as luck would have it, we have some ultrasonographic images. Rather than ask you guys to interpret just still ultrasound images, I can walk you through what we're looking at here. So this is an image that I acquired while evaluating the stomach. These arrows have been added later, so they are not part of the image that was originally acquired. What we can see is the gastric antrum, essentially. So not quite the pylorus, but we've got this hyperechoic structure within the lumen of the gastric antrum, and it's very heavily shadowing. And just adjacent to it, we can see that as well as there being this shadowing structure within the antrum, we've got a whole bunch of echoic fluid ingesta within the gastric lumen as well, which goes some way to account for the radiographic appearance of the stomach. So the stomach was almost uniformly radiopaque, and it's because it's kind of full of fluid and full of whatever this is. Now this structure that was sort of within the gastric antrum, and that actually extended towards the pylorus. And as I move my probe to evaluate the pylorus and the duodenum, this is the sort of image that I was getting. I don't think it would be entirely unreasonable for me to open up the floor and say, what do you guys think we're looking at here? So this is duodenum. So the labeling gives it away.
It seems to me that there's a large linear opacity through the duodenum.
Yeah, absolutely. So this is the duodenal lumen, essentially, and we've got this linear hyperechoic structure within the lumen of the duodenum. Now that shouldn't be there, and the fact that we can see that in combination with a whole bunch of shadowing hyperechoic material within the stomach should start ringing some alarm bells. Now, as well as seeing this linear hyperechoic structure within the duodenal lumen, I want you guys to take this image and brand it on your memory, because this is a really nice example of what small intestinal plication looks like on ultrasound. So if we look at the wall of the intestine either side of this structure, we can see that it is really concertinaed. So this small intestinal wall, this duodenal wall, is seriously bunched up. So we've got plication of the duodenum either side of whatever this structure is. Now, one of the things that I'd like you guys to do is to just take a look at this ultrasound image, and just for a second take a look at what the plication looks like, and the fact that this concertinaed small bowel creates these little kind of gas pockets, because all the bowel is all bunched up around whatever this structure is, and in bunching up, it creates little gas bubbles, little areas for gas to accumulate in between the small intestinal wall that's all bunched up. And if we go back to the radiograph, then there absolutely is the suggestion that there are two distinct populations of small bowel here. They don't look particularly dilated, the ones that are largest, but we've got just loads of these little areas of bowel that just look like they have little focal areas of gas in them. And those areas are also where we've got this loss of peritoneal serosal detail. And also almost like little comma-shaped areas of gas within the small bowel. And if you step back again and take a look at this abdomen, all of the bowel looks really bunched up. It's all kind of bunched up in the middle of the abdomen. And these little focal areas of gas lucency are more than likely going to be little areas of gas that are sort of trapped in between these plicated concertinaed areas of intestinal wall. So now you guys have had a look at some of the ultrasound images. So we've got this hyperechoic shadowing structure within the gastric antrum extending into the pylorus, and then this linear hyperechoic structure extending from the pylorus way down the duodenal lumen, and then this plication. What do we think we're dealing with here?
A linear foreign body.
Yeah, absolutely. So yeah, this is absolutely a linear foreign body, and this is usually the way that they present in dogs. So the dog will eat something ridiculous. It'll get stuck in the stomach at the level of the pylorus, and then it'll extend into the duodenum, and that's exactly what's happened here. So this foreign body, so some of it is stuck, so it's anchored at the pylorus, and then part of it is extending through the pylorus into the duodenal lumen, and then we've got this beautiful plication of the duodenum around this linear foreign body. So if you guys are wondering what this might look like at surgery, it looks like that. So you can see the radiographic appearance of this plication, the ultrasonographic appearance of this plication, and then also what it looks like in 3D. So this is the duodenum. So that area, so this here on ultrasound is this at surgery. So this is what plication looks like at surgery. And what I want you guys to sort of take away from this case really is just be very mindful if you see like all the small intestines really bunched up and a kind of an associated loss of peritoneal serosal detail. And if you see lots of these little kind of comma-shaped areas of gas, then just have linear foreign body on the list, particularly if the stomach looks kind of full as well. And then doing an ultrasound was absolutely the right thing to do here, because I didn't think it was entirely nailed on just looking at these radiographs. But if you do an ultrasound and you see a foreign body in the stomach, and then you see this plication of the bowel, there's nothing else that can be. That is absolutely a linear foreign body, and this dog absolutely needs to be cut. And then that's what it looks like at surgery. All right. So yeah, good job. So linear foreign body for the beagle. Great. So that takes us to number 3, which is an orthopedic case. So this is a 12-year-old female neutered crossbreed. Now this was quite a small crossbreed, as I remember, a little terrier cross. It became acutely lame, but a wee while ago, about 6 weeks ago, and during its initial examination after its acute lameness, the vet picked up the fact that it had a positive cranial draw affecting its left hind. And despite the fact that the vet initially suspected that this could be a cruciate rupture, it's not really responded particularly well to rest and pain relief. And 6 weeks down the line, it's about as lame as it was when this first happened. So we've got, I think, 4 radiographs for you guys to evaluate. We've got both the left and the right stifle, and we've got caudocranial and mediolateral views of both the left and the right stifle joints. So who is feeling like they might want to take on our only orthopedic case of the evening? Any takers? And given the lack of willing participants, I suppose if you've already contributed, then please feel free to chime in.
I wouldn't mind to do it.
Yeah, great.
So we have 4 radiographs of the stifle of these doggies, so 2 of the left, which is, I would say, they are caudocranial views and mediolateral.
Yep.
I'm going to focus more on the left because I imagine they did the right more for comparison.
Yep.
And my first thought when I saw the signalment of the dog was like, well, this is going to be a cranial cruciate rupture, which is probably as well happened. But I think this dog is suffering of a medial femoral condyle fracture, which I'm pretty sure for a cranial cruciate ligament you cannot have a pulsion fracture unless it's super traumatic.
Okay.
I'm not sure, but I guess if you have that condyle fracture, your cranial cruciate ligament is probably being involved at the same time.
Yeah. So you've kind of gone straight to your diagnosis.
Yes. Sorry.
So what makes you think that there's a fracture here?
So if you go to the medial condyle, you can see that the condyle is not as smooth as the lateral one. So there is kind of like a horn, and you can see a radiolucent line crossing it in the caudocranial. And also, if you look at the lateral, especially if you compare with the right one, you can see that the condyle doesn't appear as smooth and normal as the right one. So if you compare both of them, it's quite easy, I would say, to see the radiolucent line across the condyle and also the gap in the fracture line.
Yeah. No, I think I absolutely agree with all of that. So if we think that this is a fracture, how would you describe the fracture?
Oof. Oh my God, that's quite far away in my mind. So
what are the things that so if an orthopedic surgeon came to me and asked me what sort of fracture he was going to have to deal with, what are the things that the orthopedic surgeon would need to know about?
Location.
Yeah.
I guess if it's displaced or not.
Yeah.
It's a fracture of the medial left femoral condyle, is slightly displaced, and it's an articular fracture.
Yeah, absolutely. So it's suspicious that this is involving the joints. So that's absolutely something we want to know about.
Yeah.
I mean, this doesn't really apply to this case, but I mean, if we were being comprehensive about a description, whether it's open or closed as well. So there's no evidence this is an open fracture. So this is a closed. It's an articular fracture. What about the configuration of the fracture line? So what are the sort of terms we can use to describe that? So things like, is it complete? Is it incomplete? Is it transverse? Is it oblique? Is it spiral? Is it comminuted?
I would say it's complete, maybe transverse to the condyle.
Okay. Yeah, I mean, I think it's complete. So I think this is the fragment here.
Yeah.
So there's a little step in the articular surface of the medial condyle, and there's also a little step here, just on the medial aspect of that distal femur. And I think what that's created is this roughly kind of triangular shaped fragment that is made up of almost the entire medial femoral condyle. Now, I think the fissure line here, I would probably describe it as sort of as a oblique rather than transverse. So transverse fracture would be one that just sort of bisects the diaphysis. That's a little bit more oblique. It's intra-articular because we've got this step along the articular surface, and it's complete. And then you mentioned that we'd need to describe any displacement of the fragment as well. So do you think, how do you think this fragment is displaced? I
would say it's a little bit displaced.
Yeah. And in what direction or directions?
So it displays dorso medially.
So let's have a think. So because we're dealing with the stifle here, so we're still on cranial and caudal and proximal, distal, and lateral and medial.
Proximal medial then.
Yeah, I think that's probably fair. So I think we've got this fragment here, and I think it's displaced proximally, maybe a little bit medially. And I think if we look at the medial-lateral view, I think this is probably the articular surface of the lateral condyle, and then this is going to be the medial, and then this is our step, and then this is probably our fragment here. And I think it's maybe displaced a little bit caudally as well. So it's displaced a little bit proximally, maybe a little bit medially, and a little bit caudally. So yeah, that's what this dog had. Inexplicably, it had managed to sort of fracture the end of its medial femoral condyle. No idea how it managed to do it, but that is what's going on here. And I think these are actually pretty tricky radiographs to try and interpret, because that isn't really what you expect to see in a dog presenting with this sort of signalment. You're looking for a cruciate rupture. So just out of interest, what sort of things should we be looking for in a straightforward cruciate rupture?
I mean, I think this dog has it a little bit as well. Joint effusion, I think the fat pad is being slightly displaced.
Yep.
And you will also, if it's a chronic one, like in this case can be considered chronic, you will see mild changes in the joint, like osteophytes.
Yeah, absolutely. Yeah, so you're looking for an increase in opacity of the stifle joint. You're looking for compression of the infrapatellar fat pad. And I agree, I think there is some effusion here and some compression of that infrapatellar fat pad. So you could be right, there could be a cruciate injury here as well. And also, as you say, particularly in dogs with chronic cruciate ruptures, there's going to be some osteoarthritic changes. So you're going to see osteophytes on the patella, on the trochlear ridges, and then on the tibial plateau and the medial and lateral tibial epicondyles. Not a huge amount of degenerative change here, just a little bit. There's a few osteophytes here and there, but again, not necessarily as many as you might expect if this was just a straightforward cruciate rupture. And again, this big old fragment just hanging off that medial femoral condyle. So yeah, that's what this dog had. It had a fracture when everybody was expecting it to have a cruciate rupture. So yeah, nice job. We don't necessarily need to spend too much time lingering over the radiographs of the right stifle because they are pretty much there for comparison purposes. All the action is on the left. So do any of you guys have any questions at all about this case? Okay, everybody happy? Everybody saw the fracture? I thought this was kind of tricky. All right, so case number 4 is a 4-year-old French bulldog, and it's presented to you guys coughing. So we have 2 radiographs. We have a left lateral, and we have a DV. All right. So this is case number 4. So if anybody hasn't got involved yet, and they are waiting in the wings and bursting to assess this case, now's your chance. Who would like to do this one? Any takers at all? Okay. So, I mean, I can start to interpret this radiograph, and you guys can chime in when you feel you might want to add something. So this is...
I can do it if you want.
Yeah, great.
Okay.
That's great.
Can I just see the DV, or if you can zoom a bit the lateral also, because
So I can't zoom, unfortunately, but
Okay,
I
because
can flick between the DV and the lateral for you.
Okay, so we have two thoracic projection of a skeletal immature dog. There is one right lateral and one DV.
Yeah.
So the dog presents few like congenital vertebral abnormalities.
Yeah, absolutely.
Which is they are pretty, paraphysiological in brachycephalic dogs.
Yeah.
I cannot see anything else in the musculoskeletal structure, so just this hemivertebrae.
Yeah.
And regarding the chest, I can tell you that it is a bit difficult because the image is quite small. Okay. So I think there is unstructured increased opacity of the background of the lung field, which is quite mild, and it may be related with the fact that essentially the radiograph has been taken at the peak of expiration, they're expiratory, so it can be artifactual. There is a sort of increased opacity within the cardiac silhouette, so there is something that essentially border face the cardiac silhouette. In fact, I cannot totally see all the cardiac silhouette shape. Also, it's difficult to visualize. If this is right, I think it's the left cranial bronchus. So I cannot properly see. Do you know the lobar vessel and the bronchus also? And I'm not sure if there is a sort of vesicular pattern. Because it's quite small. And
near this area.
Yes, and it can be vesicular / alveolar pattern. It's not easy. And what else I can tell you? Also, there is a bit of the dorsal to the carina, the esophagus is gas filled, and you can see essentially the tracheal sign, the tracheal stripe, because the esophagus is gas filled, and you can see also the longus colli, the muscle that is ventral to the thoracic vertebrae. For the part of the cranial abdomen included, we can see a gas-filled stomach fundus. The liver looks within the costal arch, and then there is poor serosa details on the dorsal mid-abdomen. Probably is an overcrowding of small bowel. So yes, I cannot really assess. So. Give a name. Well, well, I'm not sure.
So you can request other imaging modalities for this case as well.
Well, I can request a CT, but I can put on. My differential diagnosis, they can be oh my God, lung globe torsion. Because I cannot see the bronchus. It seems there is a sort of abrupt ending, and I can put also in differential diagnosis aspiration pneumonia. But if we can have a CT, it would be great, to be honest. Or if we can have, better X-rays, it would be great also.
No, I think requesting a CT here is very reasonable. And fortunately, we have one. So let's take a look at the CT. So I'm just going to play this through for you guys, and you guys can just take a look, and then we'll go through it a little bit more slowly. So let's just run through it. All right. So, did anybody see anything funky in that CT? I'm going to run through it again, and we'll pick up on some of the things that we've already mentioned, and just use the CT to help us be more confident about making our diagnosis. So let's sort of start.
Well, there is the esophagus. There is an hyper attenuating material within the esophagus.
Yeah. So we've got this structure here. Now, because I'm driving the CT, I can't use my laser pointer. So actually, you know what? Let's actually just flick back to the laser pointer. So this thing. So that is a structure within the esophagus that essentially shouldn't be there. So that's a bit of a worry. If we move more cranially, so now we're at the level of the larynx, we're not really seeing anything else in the esophagus. So we've got the Hyad apparatus here. This is the larynx. We can see that there's an ET tube in the trachea. If we just run it on, then there's this big hyper-attenuating structure within the esophageal lumen, just cranial to the thoracic inlet. And as we move into the thorax, and so this is a soft tissue reconstruction rather than a lung reconstruction, but we can still see that there's an increased attenuation to the ventral aspect of the left cranial lung lobe here. Let me just get my pointer just here. And if we run it on, we can see that there's similar changes, so consolidation and abroncograms within the left caudal lung lobe. Just here, so we've got a bronchus, it's surrounded by consolidated lung, so we could potentially call that an abronchogram, definitely consolidated, which fits with the radiographic assessment that this patient might have an aspiration pneumonia. And if we run it on, then yeah, those are sort of the main changes in the lung. So the distribution is ventral, and the change is consolidation, because we can see bronchograms. We know this patient has been vomiting, so an aspiration pneumonia is absolutely what's most likely. And if we're looking for a reason for this patient having aspiration pneumonia, we've got this thing that's in the esophageal lumen. So you guys happy to say what you think this might be?
Well, it may be an esophageal foreign body.
Yeah, absolutely. So this patient could absolutely have an esophageal foreign body, and in fact, there isn't really anything else that thing could be. That conformation, that attenuation, it's got to be an esophageal foreign body. Now, one of the reasons why I've shown you guys this case is because for the life of me, I cannot see that esophageal foreign body in these radiographs. And I think that's just kind of scary, really. So I had the advantage when I was evaluating this case of knowing that this patient had eaten something that it shouldn't have eaten, and it had started coughing afterwards. So I knew that there was a good chance that this patient might have an esophageal foreign body, which is why we included the head and the neck in the thoracic CT. I think you did a really great job of describing the radiographic changes here, and I think you're absolutely right that there is an increased opacity in the ventral thorax here, superimposed over the cardiac silhouette. In terms of kind of a lung lobe torsion, we're not really seeing some of the other changes that we'd expect to see if it was a lung lobe torsion. So the affected lobe usually gets big. You can also see kind of a small volume pleural effusion as well. And the sort of vesicular emphysematous type change, I kind of see where you're going, because we've got these kind of little bronchi, but it doesn't look typical for me. This dog, it's a French bulldog, so if it was going to have a lung lobe torsion, it would probably be one of the cranial lung lobes rather than say the right middle lung lobe, which is what we'd see in a very deep-chested dog like an Afghan. So I think it's reasonable to consider it, but I think it's further down the list relative to aspiration pneumonia particularly. given that we know now this dog's got an esophageal foreign body. So yeah, nice job with the radiographic interpretation, and yeah, nice job with the CT interpretation as well. So we'll just run through it one more time and just take another look at this esophageal foreign body, which is just there, and then also the aspiration pneumonia, so just the ventral consolidation, those are bronchograms. So this dog went and had endoscopy, and that's what came out of it. So that's the esophageal foreign body, and that's a bit of a milk bone. So this dog had been given a milk bone, and it had tried to scoff it way too fast, and part of it had got stuck in its esophagus. And part of the reason why I think this case is so interesting is because, like I say, I really don't think that you can see that esophageal foreign body on the radiographs, and it is as plain as day on the CT. I was a little bit tricky in that the history that I gave you was that this dog was coughing, and that helped diagnose the aspiration pneumonia. And I was at an advantage because when I was evaluating this case, I knew that this dog had been eating a milk bone prior to developing the clinical signs, which were coughing predominantly, not vomiting or retching. And on the CT, it stands out beautifully. On the radiographs, it's really tricky to see. So yeah, nice job. All right. Do any of you guys have any other questions about that case? No, everybody happy? So that was the last case of the evening. Do any of you guys have any questions about any of the cases that we've dealt with this evening? We have a rodenticide toxicity, we have a linear foreign body, we have a fracture, and we have an esophageal foreign body. Everybody happy with all of those cases?
Sorry, can I ask you regarding the first case?
Yeah, let's go back.
Regarding the vessels, on the lateral, they look like a bit shrink.
This one?
Yes.
Yeah, I agree. So I think the... So yeah,
also the vena cava, yeah.
Yeah, and yeah, these vessels, they're not huge. So you're thinking that you might want to give this dog like a hypovolemia as a possible differential?
Well, but then it doesn't explain, well, it may explain the tracheal collapse probably because of fluids within, the tracheal mucosa, but
yeah,
that is going to be a really, I think, a severe grade of hypovolemia, I think.
Yeah. I mean, I suppose, yeah, I could buy that the heart maybe looks a little bit small on the DV, and some of these vessels look maybe a little bit smaller than I might expect. Yeah, I think that's reasonable. No, actually, in the DV, the DV
looks fine to me.
Actually, yeah, they look okay in the DV, and they don't look too bad here either. The artery, the bronchus, and the vein. Okay. All right, but you guys, it's difficult for me to explain the mechanisms that result in the trachea looking narrow, other than just to say, if you think about the trachea in a short axis view, so a transverse view, and then you think about the mucosa filling up with fluid and then bulging into the lumen, and then turning it from a short axis transverse view back into kind of a long axis sagittal view, then it's going to look like this. And yeah, it's something that is really worth knowing about, because you'd never guess that a rodenticide toxicity might look like this with narrowing of the tracheal lumen, but it absolutely does, and they are out there, and hopefully if you guys see one again, then you'll be able to nail it. All right.
Thank you.
That's okay. Everybody happy with all these cases?
Thank you very much, Ewan.
Yeah, great. All right, so thank you guys for attending. I know that circumstances are very strange, and we are living in interesting times at the moment, but we will endeavour to continue to hold these film reading evenings. Hopefully we'll get to do the next one next month as normal, so last Wednesday of the month, and I hope to see you all there. And if you have any friends, any colleagues who would like to get involved, then yeah, spread the word, and the more the merrier. So yeah, have a lovely evening and stay safe. And yeah, I will see you guys again soon, hopefully at the next film reading evening. All right.
Thank you very much,
Okay.
Ian. Have a good evening.
Thanks, guys.
Bye-bye.
Thank you.
night.
Stay safe.
And you. Stay
Thank
safe.
you. Thanks, Ian. Have a good evening. Bye.
Thank you. Bye-bye then.